definitions that are based on the baselines, such as the one popularized by Dr. Susan Hu, and a number of other definitions, sudden rise of creatinine to greater than 2. And in all, if you count it up, approximately 30 distinct definitions were in use in the medical literature. So again, prior to 2004, there were a number of definitions. And in 2004, the Acute Dialysis Quality Initiative meeting took place. And the intention of the organizers and the members of that committee were to come up with a standardized definition of acute kidney injury, a consensus-based definition that would permit more standardized comparisons of incidence and mortality across studies. And these were the Rifle criteria, which I'll describe in just a moment. In 2007, the Rifle criteria were tweaked a little bit. They were updated by the Acute Kidney Injury Network, and they proposed the AKI criteria. In 2009, Dr. Bonventry and I performed a computer simulation of creatinine kinetics and proposed a new definition of acute kidney injury based on small changes in creatinine over a short time period. And finally, in 2012, the KDIGO consensus conference took place, and a new definition of acute kidney injury was proposed. So I will focus on the KDIGO definition. So the kidney disease improving global outcomes definition is a rise in serum creatinine of 0.3 milligrams per deciliter within 48 hours, or a 50% increase over baseline in 7 days. The KDIGO definition also encompasses a urine output criterion, so oliguria of less than 0.5 milliliters per kilogram per hour for 6 hours was also used to define acute kidney injury. So this slide is intended to show some of the comparisons across definitions. So the Rifle criteria, which were the first in 2004, the definition was a 50% rise in creatinine within 7 days. And then the condition was staged according to the severity, according to the magnitude of creatinine elevation. Rifle also introduced oliguria as a defining feature of acute kidney injury. The AKI criteria added a 0.3 milligram per deciliter increase within 48 hours to the Rifle criteria and retained the staging system of 3 distinct stages. And then KDIGO, most recently, defines acute kidney injury as a 0.3 milligram per deciliter rise or a 50% rise within 7 days. And the staging is quite similar to both Rifle and AKI, which are its predecessors. And the definition that Dr. Bonventry and I proposed was 0.3 or 0.5 milligram per deciliter rise within 24 or 48 hours, and then staging based on larger magnitude rises. Interestingly, if one looks at outside of our field, so outside of nephrology, the definition of acute kidney injury is different. So the European Society of Urogenital Radiology defines AKI in the setting of contrast as a serum creatinine rise of greater than or equal to 0.5 milligrams per deciliter, or a 25% rise within 48 to 72 hours of contrast exposure. And in the original article describing that definition, there was substantial disagreement among investigators. The hepatorenal syndrome, according to the International Ascites Club, is defined as a creatinine of greater than 1.5, or a 24-hour creatinine clearance of less than 40, and an absence of other causes or improvement in creatinine with fluid administration. And then finally, the heart failure specialists term cardiorenal syndrome, at least according to some studies, as a creatinine rise of greater than or equal to 0.3 milligrams per deciliter with no clear time frame established. So have we gone from this morass of multiplicity of definitions to this, where we have AKI, Rifle, KDIGO, distinct definitions of contrast nephropathy, distinct definitions for worsening renal failure or cardiorenal syndrome. So KDIGO is actually has attempted to produce a consensus conference or a consensus definition, as have Rifle and AKI, incorporating intensivists, critical care nephrologists, and nephrologists to produce a consensus definition. And so let me just make some commentaries on comparisons of the AKI definitions. So the first consensus definition, Rifle, was the first one. It has had multiple validation studies showing that rifle gradations of acute kidney injury are associated with poor outcomes. It has been widely used in epidemiologic studies. It's also the first to incorporate urine output into the definition. One of the limitations of the rifle was that it relied on percentage rises in creatinine over baseline. The akin definition built upon the rifle criteria and added a 0.3 milligram per deciliter rise. There's been some criticism, especially from non-nephrologists, that such a small increase in creatinine was not clinically relevant. A definition that Dr. von Bentry and I proposed was based on mathematical modeling of creatinine kinetics, potentially allows earlier diagnosis of acute kidney injury as it doesn't require a percentage rise over baseline. And finally, KDIGO builds upon both the rifle and the akin criteria. So I'm frequently asked by my colleagues in medicine and surgery, does it make a difference how you define acute kidney injury? So we undertook a study at Brigham and Women's Hospital of about 32,000 admissions during the year 2010 to see how the incidence estimates of acute kidney injury vary depending on how the condition is defined. So on the y-axis here is plotted the incidence of acute kidney injury, and according to various definitions, rifle, akin, KDIGO, and the definition based on creatinine kinetics. As you can see, 16.1% of hospitalizations at the Brigham met criteria for rifle, 16.6% met criteria for akin, and then 18.3% met criteria acute kidney injury defined by KDIGO, also had acute kidney injury defined by akin and rifle. And in fact, the concordance was 98%. So the vast majority of patients are similarly defined and staged between the KDIGO definition and akin and rifle. KDIGO actually diagnoses AKI most frequently, so the highest incidence is seen with KDIGO, and it also stages AKI slightly higher than the other definitions. And the reason for that is that the 0.3 milligram per deciliter rise and the 50% increase criterion are both within first 48 hours for the absolute rise, and then 7 days within for 50% rise. So one question that comes up is this believable? Is it really possible that 1 out of 5 or 1 out of 6 of our patients hospitalized at a tertiary care hospital in Boston has acute kidney injury? Or are we overdiagnosing the condition? So let's take a look at how outcomes vary according to the definitions. So this is again based on 32,000 patients at Brigham and Women's Hospital. We looked at incidence, mortality, length of stay, and hospital costs across the definitions. I apologize for the small type font, but you can see that the highest incidence is seen with KD admission, the reason for hospitalization. And acute kidney injury is extremely costly. So this is US dollars, thousands. So between 6,000 and 11,000 approximately dollars in excess costs attributable to the development of acute kidney injury. So what does one conclude on the basis of all these? I think what this shows is that all definitions of acute kidney injury show the same pattern, that AKI is associated with increased mortality, increased resource utilization. And if one looks at the staging criteria across the definitions, the results are quite similar. Akin stage 1, 2, and 3 shows the same graded increase in mortality as KDIGO, shows the same increase in mortality as rifle, and same with the definition that was based on creatinine kinetics. So then which definition is best? So I would submit to you that it's on the basis of these studies one can't really adjudicate a best definition. And the reason for that is that definitions of acute kidney injury are not intended to provide prognosis. Therefore, comparing odds ratios for mortality or C-statistics in a logistic regression model are not really relevant for whether a definition is useful or not. What I think a definition of acute kidney injury should do is enable epidemiologic and research studies, and also ultimately improve or standardize clinical care. So rifle, akin, and KDIGO have been extraordinarily valuable for standardizing the definition of acute kidney injury, for permitting epidemiologic studies and comparisons across regions and across time. Whether or not they've improved or standardized clinical care, I think, has yet to be determined. I think there's still concern about the possibility of overdiagnosis with KDIGO and also with rifle and akin. Is 18.3% incidence at the Brigham and Women's Hospital truly believable, or is the definition too permissive? So there may be some need to further tweak the definition to adjust it so that not too many patients are included. And so the limitations that I would submit to you of the leading definitions of acute kidney injury are as follows. The first is the urine output criteria. Some studies have examined the urine output and showed that low urine output is associated with mortality. Whether that's a reasonable way to define acute kidney injury is something that I think we still have to consider. There's been some disagreement in the literature on that. The use of percentage rises over baseline, I think, is a problem. It results in delayed diagnosis. And also it results in potentially spurious diagnoses in patients with low baseline serum creatinine. So if you come in with a creatinine of 0.4, a 50% rise is just a 0.2 milligram per deciliter increase. And then the use of small changes in creatinine to diagnose acute kidney injury has been criticized, especially outside of nephrology, at least in my clinical experience, as identifying patients who don't truly have a disease or a condition that warrants a diagnosis of acute kidney injury. So to conclude, I think the KDIGO definition of AKI is a thoughtful combination of rifle and akin. It's extraordinarily valuable for epidemiologic studies. I think the jury is still out. It still remains to be determined how that will be incorporated into clinical care. I think the urine output criteria of rifle and akin and KDIGO still needs to be validated, and not from an epidemiologist's perspective, but rather from a clinician's perspective. It is certainly the case that oliguria is associated with poor outcomes. The question is whether adding oliguria as a criterion to define AKI is ultimately going to improve or standardize clinical care. And I think the high incidence of acute kidney injury, 18.3% according to KDIGO, suggests that maybe the definition is too permissive and that we're going to have an epidemic of acute kidney injury that's not truly a disease. But again, the KDIGO definition I think are extremely valuable. I think there will be modifications in the future, but so far it's the definition that I think is being used widely in the epidemiology literature. So thank you very much, and I'd be happy to take questions.
Is that when you say overdiagnosing AKI and creating an epidemic, this is a concern that mostly comes from people that still confuse AKI with acute renal failure, needing dialysis. You know, every time you do a kind of a handwork, you injure your hands. Very strong, very little, doesn't matter. Every time you come to the hospital, probably with antibiotics or other therapies, you injure your kidney. And even if you have one nephron affected by any type of therapy, to me, this is an injury. So I think that we have to be very careful in saying that we possibly overdiagnose, because I think the entire notion of having the whole number of nephrons perfectly working is very important for kidney function, especially in light of what's going to happen in 10 years from now.
Thank you, Dr. Marco. I appreciate your perspective. I see it a little bit differently. I worry that labeling 18% of our patients as having acute kidney injury is actually going to distract attention from those who actually need care. We still don't know how to treat severe acute kidney injury, so I don't think we need to expand the diagnosis to include injury to single nephrons, as you're suggesting. But I do appreciate your perspective. You're right. There is a lot of kidney injury going on in the hospital because of antibiotics and toxins, and whether or not labeling those as acute kidney injury is something that I think we'll have to see whether it improves ultimately the care of our patients.
I love my nephrons.
Students from the UK, you kind of tiptoed around baseline creatinine or providing us with your take on the definition of that. So could you perhaps comment on that for us, please?
Sure. So the KDIGO supplement in Kidney International goes over the how to diagnose based on baseline creatinine. If it's available, it can be used and should be used, but oftentimes it's not. Eddie Sue from Vanderbilt had a nice paper recently that took the average of creatinine measurements within the past year to use that as the baseline and showed that that was probably the most sensible approach. So if creatinines are available, averaging them over the past year is one approach. If there is no creatinine available, some have advocated using a baseline that is back calculated from normal. And there's some problems with that, particularly in overdiagnosis again. So if someone comes in with a creatinine of 2 and they're presumed to have a baseline creatinine of 1, and their actual creatinine of 2 is their true baseline, then we're overdiagnosing chronic kidney disease as acute kidney injury. So I think there's some problems with using that approach. So if there's no baseline available, what I would do is look at the lowest creatinine, for example, during a hospitalization. But that doesn't help in diagnosis in real time. But if there's an increase in creatinine, irrespective of the baseline, and say 0.3 within 24 hours or 48 hours, that could be reflective of acute kidney injury. So I think there's still some modifications that are necessary to figure out how to define it in the substantial proportion of patients who don't have a baseline creatinine. It's a difficult matter, I think.
In the interest of time, I think we can entertain 3 more short questions. Please keep the question and the answer short. Excuse me, the one behind first. Sorry.
Dr. Fan Ho from mainland China. So in patients with cardinal renal syndrome, AKI may occur in patients with chronic kidney disease. How to define this acute and chronic AKI?
Well, I think in those who have chronic kidney disease, changes in creatinine from baseline may be less relevant. So a 0.1 or 0.2 increase from a baseline of 3 is clearly within laboratory error, whereas that same rise from 0.6 is much more significant. So I think using the KDIGO criteria of a 0.3 milligram per deciliter rise within 24 to 48 hours, my preference is 24 hours, but within 48 hours is still going to permit identification of acute and chronic kidney disease.
Yes, maybe gentlemen first.
Shrut, Colorado. Thank you for your presentation. Just a comment about the urine flow criteria. We know about 50% of patients have non-overt AKI. Obviously, you can't use the urine criteria there. And even on the other side, if you have really good kidney function, low solid intake, you can get the urine flow down pretty low. And if you add urinary sodium and it's less than 10, the tubule's functioning well. So it's hard to call it AKI. So I think there are certain important caveats about using the urine flow criteria.
Thank you for your comment.
From Beijing, Peking Union Medical College. My question is about the definition. As we know that the RIF line at the very beginning, most of the physicians are from critical care doctor. But as a nephrologist, we know that the patient is different. Most of the critical patients are sepsis or HNA. But for nephrologists, we have more other primary or secondary glomerular disease. So should we add the cause of the AKI to the definition because the outcome is different, especially because of the different treatment?
Yeah, I think that's a very good point. These definitions are intended to have a broad catchment, so identifying a variety of causes, including ATN and other causes of acute kidney injury. But I think you're right that there are causes of acute kidney injury outside of the intensive care unit, and identifying the cause is absolutely important, and defining a disease as AKI should not promote diagnostic laziness on the part of clinicians. We should still pursue a differential diagnosis.
Thank you very much, Dr. Walker.